we all know that we need a public option. To us, I think most of us here recognize that. I actually spent time out at the remote area medical event. We actually organized the pediatric section of the event with them. In 8 days, we saw over 8,000 patients. These were mostly working poor. These were not, this was not primarily illegal immigrants there in any way, shape, or form, probably less than 1%. Were actually undocumented. We didn't ask for documentation, but clearly when we talked to them and we asked for information, because we asked about it, so we would get a sense of what's going on, and people were very honest about it. They were very excited to be able to get any care that they could. So to me, looking at the issues of a public option, what are we looking at? The key components are that we do need competition in the insurance market. There is no doubt about it. And we need something that's going to keep the costs low. If you're going to mandate that everybody has to have health insurance, but you aren't mandating what those premiums are going to be from the insurance companies, then how do you do that? So you can't have your cake and eat it too unless you do both pieces. So ultimately, we need this aspect of this component unless you're going to mandate and now regulate premium levels for all the insurance companies. And I would love to see the state insurance commissioners get away with that one. So the only way that happens is through competition. And the intention that I see from the public option, again, there's not a whole lot here in any one of you, since it's only about 16 pages altogether, you should have no problem reading it, is that it does call for increased provider reimbursement, by about 5% in the initial year, to try to help defray any initial costs. But ultimately, what we need to be clear about is, it is part of the exchange. It's part of the insurance exchange program. So it's just like another HMO that has to contract with provider clinics and doctors and other providers to give services. So I don't think all of us as nonprofit clinic systems and nonprofit hospitals are going to go anywhere, because they have to have providers to create this public option, and quite frankly, they need us. Without us, they don't have a public option. So ultimately, I think there just needs to be a clarification, perhaps in here, that says we want to work with our nonprofit organizations and help them to become our providers as part of this public option. And I think that was the intent. And again, the beautiful thing is you put 12 people in a room with these 8 pages, and they're all going to have a different interpretation of it. But that's my sense of it, and that's what I'm hoping we could maybe clarify a little bit from Congress, from looking at these issues. Excuse me. So when you really look at the key components, it talks about trying to keep premiums, looking at the research that's related to each of the communities that it's going to be operating in, so that they try to keep premium levels reasonable for the level that it's in, but setting a standard that the other insurance companies do have to compete with if they want to get any of these lives, per se, right, those capitation lives. So it's really very much that simple as far as I'm concerned. I do feel strongly that we need to educate the public on what this means. The key word here is option, not commandment. It is a public option, so it is something in addition that becomes part of the health exchange network of insurance providers, and we need this for the gaps that we exist right now. Are 55 to 65. They don't qualify for Medicare. Some of these people are not, they're semi-retired. Their insurance is getting out of control expensive, and so therefore they don't qualify.
Calling anything right now public is a bit dangerous, because sometimes we have good experiences, sometimes we have bad experiences. Sometimes we have good experiences with public education, even though we like the mandate. We like our teachers, we don't like our principals. Of some of our schools. So if they could have called it something else, really from the get-go, or reframe the debate on what is defined by the word public. Because obviously it's not 8 pages. It's like someone said one time, I don't want the government involved in my Medicaid or Medicare, or, more, and that's really, really important. And I think the political left sometimes ignores marketing. Because they think they're right. They prefer to be right than win. And I prefer us to win than be right.
When you look at the insurance industry, the sheer size of many of the major players in the health insurance industry, that in many regional markets or local markets define, 50% of the lives are covered by 2 major health plans. So that near monopoly, it's one aspect that the public option would, immediately, sort of tackle. The second one, she already mentioned, which is this fact of competition and that competing on quality and cost. But secondly, you know, by having a public or nonprofit model, you know, and hopefully not have that high compensation of CEOs and really the loss ratio being more reasonable, that will put a downward pressure on the other plans to, you know, to contain costs, something that you don't see today. And thirdly, as we were talking earlier, I mean, this whole thing is going to take time to implement. To the extent that we have reforms to the insurance market, you know, you may still continue to see abusive practices, you know, with rescission or what have you. And so consumers are going to need a place where they can go if these practices or, you know, these regulations are not actually being implemented to the degree that they should. So, I mean, one of the problems, again, is how you're going to establish that provider network, you know, overnight, you know, the coverage of the provider network. I think that's what you were referring to as well. And one argument that I've heard from conservative commentators, and I'm not quite, you know, again, this is all vague, so I don't know how it relates totally to the exchange, but as far as the pay or play aspect of this, you know, the incentive to employers to drop their own employer-sponsored coverage and just tell their employers go to the public plan. I'm interested to see what others may think about that. In California, we had the experience with Healthy Families, and I was trying to remember what we called it. Finally came to me, crowd out, you know, and we didn't see a major problem with that in California. So I wonder how the bill actually tries to, you know, sort of preempt that argument and what people ideas might be on that.
Assuming most of you support the public option, what unique contribution can this group give to that debate? Why, from your perspective as providers of care to largely low-income vulnerable populations, does the public option offer a particular value as opposed to the broader dialogue we're having? Yeah.
I know many individuals that have HIV and AIDS and are on have a chronic condition that especially HIV and AIDS that remain in the Medicaid system because they were at one time qualified for it based on their condition, but their condition has improved. But they remain in this Medicaid position because they cannot, first off, they're afraid to lose that by going back to work. They're afraid to lose that access, and they cannot just go and open a small business or anything and go put on a piece of paper, I have HIV and AIDS and it costs me $1,500 a month for my medication. They'll never get insured. If I were to leave my job, my medications, I'm a person living with HIV, are costing $1,200 a month. I would not be able to open a small business and go buy health insurance. People like me and people in this position have to be insured that they can have access to care. And it is not happening in the general private system right now. People are in this system, they're not leaving, they may become healthy, may be able to work, but you lose these benefits and there's this fear of getting off this Medicaid program because of continuity of care.